You know that feeling. Heavy, tired legs at the end of the day. It's so common we often just ignore it.
Right.
But what if those feelings, maybe even more serious problems, were actually a sign of something going on with the major veins in your legs and pelvis?
Exactly. We're talking about conditions called Iliocaval Venous Obstruction and pelvic congestion syndrome.
Okay.
These involve uh, disruptions, could be blockages, could be faulty valves and those big veins returning blood from your lower body.
So iliocaval obstruction, that's the iliac veins in the pelvis and the vena cava, the big one in the abdomen.
That's the one. And pelvic congestion syndrome, or PCS, mostly affects women and involves the veins specifically in the pelvic area.
Okay, let's unpack this. For this deep dive, we've got some serious source material. We're looking at chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Yeah, that's a major medical textbook. Top tier stuff.
So we're getting right to the core here. Our mission, really, is to pull out the key insights so you can quickly get the gist of these conditions and, crucially, understand when surgery might actually be on the table.
And what's interesting, is that treating these veins surgically hasn't always been common practice. The first successful repair of a major vein, it was actually reported over 50 years ago now.
Wow, okay.
Since then, the techniques have really evolved alongside better diagnostic tools and, well, better materials for the repairs themselves.
And I know now we hear so much about less invasive options like endovascular treatments, stents and things. So where does open surgery fit in today?
You're right. Those minimally invasive methods are often the first line of attack now for many blockages in the iliac and iliocaval veins. But surgery is still really vital for cases where those methods, well, maybe they fail or they just aren't the best fit for a particular patient's situation. It's another important tool in the kit, especially for complex problems.
Gotcha. So what actually causes these blockages? It's not always just blood clots, is it?
Good question. While DVT, deep vein thrombosis, a clot in a deep vein is definitely the most common culprit, there are actually quite a few other things.
Like what?
Well, trauma, radiation treatment in that area, even pressure from the outside, for instance, from scar tissue, or a specific condition called May-Thurner syndrome.
May-Thurner. That sounds like a very specific kind of compression.
It is. It's where the right iliac artery crosses over the left iliac vein and sort of squashes it.
Ah.
Over time, this pressure can cause these little scar-like webs or spurs to form inside the vein, blocking flow. They actually saw these in some early autopsy studies.
Spurs inside the vein. Wow, so it's a physical squeeze. What else can block them?
You can also have tumors, either benign or cancerous, cysts, even aneurysms, those bulges in blood vessels pressing on the veins.
Right.
And sometimes it's things like muscle bands that are in the wrong place, like with popliteal vein entrapment behind the knee, or tight tissue bands, like the soleal arch in the calf, or even the inguinal ligament in the groin pressing on the femoral vein.
So a whole range of physical blockages.
Exactly. And then there are congenital things, too, problems people are born with,
Huh.
like a membrane blocking the top part of the vena cava that's often linked to Budd-Chiari syndrome, which affects liver veins, or, veins that are underdeveloped or missing, like you see in Klippel-Trenaunay syndrome. It's quite a variety.
That really is a lot of potential causes. So, okay, before you'd even think about surgery, what kind of evaluation is needed?
Oh, a really thorough workup is absolutely key.
Mm.
We need to pin down not just the cause, but how much it's actually affecting blood flow.
Mm.
And importantly, are there any issues with the valves inside the veins? Are they leaky, letting blood flow backwards? That's called reflux.
And I guess the symptoms give a lot of clues. What are doctors looking for when they talk to and examine someone?
Yeah, patients often report swelling in the lower leg, maybe pain in the thigh when they exercise. That's called venous claudication.
Okay.
It's often described as a sort of bursting pain that feels better when they rest and put their leg up. Doctors also look for signs of long-term vein trouble, CVI, chronic venous insufficiency. That includes swelling, varicose veins, skin changes on the leg, maybe even ulcers. If the blockage is higher up in the pelvis, you might actually see big dilated veins on the lower abdomen or groin. Sometimes those can even bleed because of the pressure.
Oh, wow.
The leg might look a bit bluish, and if both legs are really swollen, that points towards blockages in both iliac veins or maybe even the vena cava itself. Interestingly, some people might get excessive sweating or fluid loss from the skin, and sometimes it can contribute to lymphedema, which is a different kind of swelling.
That sounds like a really detailed check. What about imaging? Is ultrasound the first step?
Usually, yes. A
Right.
duplex ultrasound is the go-to first test. It's great for looking for clots, like DDTs.
But
But, well, sometimes it's hard to get a really clear view of those big veins deep inside, like the IVC or the apoiliac veins. Things like bowel gas or just body tissue can get in the way.
okay, so then what?
In those cases, we might use CT venography, a CT scan with contrast dye for the veins, or an MRI. Both give really detailed pictures and can help identify the cause of the blockage, like a tumor or scar tissue, or that May-Thurner compression.
And are there findings on the ultrasound itself that are clues?
Definitely. If there's no blood flow seen, or if the normal sort of pulsing flow pattern in the leg veins is lost, those are big red flags.
Are there ways to actually measure the impact of the blockage? Like, how bad is it?
Absolutely. We can measure vein pressures, sometimes while the patient is standing or walking.
Yeah.
A big pressure difference between the arm and the foot can signal a major blockage.
Mm.
We could also put small catheters in, measure the pressure directly in the femoral vein in the thigh, and compare it to the pressure in the central veins near the heart. If there's a difference of 5 millimeters of mercury or more, or if that femoral pressure doubles with exercise, that's pretty significant. And finally, there's catheter-based venography. We inject contrast dye directly into the veins through a catheter to see the blockage clearly and also check how well the valves are working. We can access the veins from the groin or sometimes the arm.
So after all that evaluation, when does surgery actually become the go-to? You said endovascular is often tried first.
That's generally the approach now, yeah. Surgery is usually reserved for situations where those endovascular treatments didn't work or maybe weren't suitable from the start.
So it's more of a backup plan, or for specific cases.
Kind of, yeah. The decision really hinges on several factors. How bad the blockage is, where it is, how long it is, how old any clot might be. Is there external compression? Is there cancer involved? And what are the patient's overall surgical risks?
Makes sense.
Endovascular treatment may be combined with clot-busting drugs or even surgically removing a fresh clot. That's usually the first attempt. The ideal candidate for open surgery. Yeah. Often someone with a blockage just in one iliac vein, not too much clot further down the leg, and importantly, good valve function in the leg veins. Studies have shown surgery tends to be less successful if there's severe long-term damage from clots below the groin, and those valves are really incompetent.
Right. So if surgery is the plan, let's talk about the grafts used to bypass the blockage. Grafts in veins, I know they use them in arteries, but veins, it's trickier, right?
That's a really important point. Yes, it is trickier. Grafts in veins, unfortunately, have a higher chance of clotting off compared to arterial grafts.
Why is that?
A few reasons. Blood flow in veins is slower, the pressure is lower, which means the graft, especially a synthetic one, can potentially collapse. Also, many patients needing these surgeries already have a history of clots, maybe underlying issues that make their blood clot more easily. And, well, the surface of prosthetic grafts can be inherently more prone to clot formation.
That sounds like a pretty big hurdle.
It is, but, we've gotten much better at keeping these grafts open over the years.
How so?
Things like using larger diameter grafts, whether they're from the patient's own body or synthetic. Also creating something called an arteriovenous fistula, an AV fistula.
Okay, what's that?
It's a connection made between a nearby artery and the vein graft. It boosts the blood flow through the graft.
Ah, interesting.
Plus, using externally supported grafts, good anticoagulation blood thinners before, during, and after surgery, using compression pumps, and keeping a close eye on the graft with Ultrarea afterwards. All these things help.
Let's dig into the graft materials then. What are the options? You mentioned patient's own veins versus synthetic.
Right. So autogenous grafts using the patient's own vein tissue generally have the best long-term track record for these iliocaval reconstructions. The great saphenous vein, usually taken from the leg, is often the top pick.
Why that one?
It tends to resist clotting well and is often long enough. Other options could be the superficial femoral vein from the other leg, arm veins, even jugular veins from the neck.
Is there a downside to taking those veins?
There used to be some concern about causing long-term leg problems by harvesting a deep vein, but newer evidence suggests it's usually tolerated pretty well, though maybe more risk if the patient already has poor leg circulation or if you take both a saphenous and a deep vein.
Okay. What about other types?
Well, cryopreserved grafts veins preserved by freezing are used sometimes, but we don't have enough solid data yet to recommend them routinely for these big vein repairs.
And the synthetic ones?
For synthetics, the most common material for large veins is expanded polytetrafluoroethylene, or EPTFE.
EPFE, right.
If it comes in the right sizes, it's readily available, often has that external ring support to prevent collapse, and it's relatively less thrombogenic, less prone to clotting than some other artificial materials.
You mentioned that AV fistula, again, the artery vein connection. How exactly does that help keep the graft open?
So by creating that connection near the venous graft, you dramatically increase the volume and speed of blood flow through the graft.
Like giving it a high pressure rinse.
Kind of, yeah. That faster flow helps wash away platelets and fibrin, the stuff that forms clots, stopping them from sticking to the graft wall. This is especially important for prosthetic grafts, which seem to need a higher flow rate to stay open compared to autogenous vein grafts.
Makes sense. But are there downsides to creating these fistulas?
There are a few trade-offs. It makes the surgery a bit longer, and importantly, it usually requires a second procedure later on to close the fistula.
Ah, okay.
There's also a small risk that if the flow is too high, it could strain the heart or even increase pressure in the leg veins further down, which you don't want. We've learned that the size ratio is key. The fistula needs to be smaller than the graft. If the pressure in the femoral vein jumps too high right after creating the fistula in surgery, that's a warning sign.
So how do they make and manage these fistulas?
We often use a small piece of vein or a short 4mm EPTFE tube to connect the side of the main venous graft to the superficial femoral artery in the groin. We can even measure the flow during surgery to make sure it's not excessive, aiming for less than about 300 milliliters per minute.
And closing them later?
Yeah, nowadays that's often done minimally invasively. We can go through an artery in the opposite leg and deploy little coils or plugs to block off the fistula. Sometimes we'll put a little silicone sheet around it during the first surgery to make it easier to find later if needed. Closing it percutaneously, just through the skin, is also an option.
So is it standard practice to use them?
Pretty much, yes. We routinely create a femoral AV fistula for all prosthetic grafts going to the femoral vein, and for iliocaval grafts longer than about 10 centimeters. We typically leave them open for at least 6 weeks. For the palma procedure, which we'll get to, we use them a bit more selectively and tend to close them earlier, maybe within 2 months.
Anticoagulation blood thinners, that must be absolutely critical here. What's the usual plan?
Oh, essential. Non-negotiable. We usually start intravenous heparin, a powerful thinner, before clamping the veins in surgery and keep it going during and right after. Often, we'll also infuse low-dose heparin directly into the vein near the graft during and immediately after the operation until the main systemic heparin dose is fully effective, usually around 48 hours.
And then long-term?
Then we switch, either continuing IV heparin or using low molecular weight heparin injections, followed by oral anticoagulation, usually warfarin.
And other measures?
Alongside the meds, yes. Inflatable compression devices on the legs during and after surgery, keeping the legs elevated, elastic bandages, and getting the patient walking early all help prevent clots. Patients go home with compression stockings too, usually 30-40 millimeter Hg pressure.
How long do they stay on warfarin?
Depends on the graft. With autogenous grafts, usually at least 3 months. But with prosthetic grafts, or if the patient has an underlying clotting disorder, it's often lifelong.
And how do you keep tabs on these grafts after surgery and make sure they're working?
We check them right there in the operating room with duplex ultrasound, look for patency, good flow, any early clots. We might take direct pressure measurements too to confirm the bypass is doing its job hemodynamically. And if we made an AV fistula, we measure its flow.
What about right after surgery?
Often on the first day post-op, we'll do a contrast venogram through that little catheter near the graft. If we see any early narrowing or clot, that might need immediate revision surgery.
And longer-term follow-up?
Regular duplex scans are key, usually at 3 months, 6 months, then maybe twice a year. We might do other non-invasive flow tests too. And of course, if a patient develops symptoms, again, a contrast venogram is usually needed to check for any problems with the graft.
Okay, let's talk specific operations. First up, the cross-pubic venous bypass, or PALMA procedure. When is that the choice?
Right, the PALMA. It's been around a while. It's a solid option when someone has a blockage in the iliofemoral vein on just one side, provided the veins on the other side are healthy and can handle the extra drainage.
So you divert the flow across?
Yeah, exactly. It tends to work best if the inflow to the blocked area is decent, and there aren't major issues like bad valves further down the affected leg. We often favor it for younger women who have a persistent left iliac vein blockage after a clot caused by May-Thurner syndrome, that compression issue again. It's also considered if stenting the iliac vein isn't feasible or if it failed. The key idea here is using the healthy side to help the blocked side, often with good results, especially in that younger May-Thurner group.
And how's it actually done? What's the technique?
Typically, you use the great saphenous vein from the unaffected leg. It's good practice to check this vein with ultrasound beforehand to make sure it's big enough and not too
Hmm.
annoying. Varicose veins under 4 millimeter don't tend to do as well long term.
Okay.
You harvest a good length of it, maybe 25, 30 centimeters, either through open incisions or sometimes endoscopically, which looks better cosmetically. You cut the lower end, but leave it attached up in the groin. Tie off any branches. Then you gently stretch it and tunnel it under the skin, across the lower belly, over to the block side's groin. You try to minimize dissection around the femoral vein on the block side, just enough to clamp it for the connection, the anastomosis.
And connecting it.
You sew the end of the harvested saphenous vein to the side of the femoral vein on the block side. If the saphenous vein is small, maybe use interrupted individual stitches so the connection can expand a bit. We might put a small catheter in for immediate heparin or a post-op venogram. And as we discussed, maybe a temporary AV fistula down lower in the leg to boost flow initially.
What if the vein graft kinks?
Good point. If it kinks badly where it comes across, you might have to detach it completely from the donor side, maybe taking a little patch of the femoral vein with it, turn it 180 degrees, and then re-sew it to avoid the kink.
Any alternatives if that saphenous vein isn't good?
Yeah, you could potentially use the saphenous vein from the affected leg, but you'd need to disable its valves, or an arm vein. If no suitable autogenous vein is available, then an 8-10 millimeter externally supported EPTFE graft is the backup.
And how well does the Palma procedure work? What are the results like?
Looking at large reviews, somewhere between, say, 63% and 89% of patients report significant symptom improvement.
That sounds pretty good.
It is. Patency rates of the graft staying open are often reported in the 70–85% range, though follow-up times vary, and not everyone gets routine imaging. One big study suggested using that temporary AV fistula improved outcomes.
Interesting.
And grafts done for external compression without underlying vein damage lower down did really well, like 100% patency in one series compared to those done for post-thrombotic syndrome. There's some debate about whether using a completely detached free saphenous graft is better than just tunneling it. Some surgeons actually advocate for using EPTFE with an AV fistula for all cross-femoral bypasses now.
Okay.
There's also evidence that pre-op tests showing poor outflow predict who will benefit most clinically. More recent studies show good one-year patency and quality of life improvements, though groin wound issues or lymphatic problems can sometimes occur.
You also listed prosthetic femorocaval, iliocaval, and IVC bypasses. These sound like bigger operations for more extensive problem.
They are, yes. These are options when a palma isn't feasible, maybe no suitable vein, or the blockage involves both iliac veins, or the connection between the iliacs and the vena cava, or the IVC itself.
What kind of situations lead to needing these?
Things like really extensive clots, maybe related to IVC filters or tumors, severe retroperitoneal fibrosis, that's scar tissue squeezing the veins that hasn't responded to other treatments, or when previous endovascular attempts like stenting have failed, or the stents themselves are blocked. These are definitely for more complex, widespread disease.
So the key takeaway is these are reserved for extensive issues where less invasive methods won't cut it.
Exactly. And they often require that AV fistula we talked about to have the best chance of staying open long term, even though they are more complex with potentially lower overall patency than simpler bypasses.
What's the surgical approach for these?
It varies. Usually an incision in the groin for the lower connection or the fistula. To reach the iliac vein or lower IVC, often a flank incision going behind the abdominal cavity. For the IVC higher up, near the kidneys, usually a midline incision down the abdomen or one under the ribs on the right. You have to move the colon out of the way.
And the grafts?
The synthetic graft size depends on what you're bypassing. Maybe 16–20 millimeters for the infrarenal IVC, 14 millimeters for iliocaval, 10–12 millimeters for femorocaval. For iliocaval bypass, you usually make the AV fistula first. For femorocaval, usually connect the graft ends first, then create the fistula. And full anticoagulation plus maybe that local heparin infusion catheter are standard.
What about the outcomes for these bigger prosthetic bypasses?
Well, the experience is definitely more limited compared to palma or arterial bypasses. There aren't as many large long-term studies. One series from Mayo Clinic showed fairly reasonable 5-year patency rates. Another small study had good results with iliac reconstructions. Our general feeling, based on the available data and experience, is that especially for the longer femorocaval or iliocaval grafts, having that AV fistula really seems crucial for maximizing long-term patency.
You also touched on combining endovascular and open techniques, a hybrid approach. When is that used?
Right. the hybrid approach. It's particularly useful for patients who have long iliac vein blockage plus chronic clots stuck in the common femoral vein down in the groin.
Why is that combo tricky?
Because that clot in the femoral vein can compromise the outflow for any stent placed higher up in the iliac vein, making the stent more likely to fail.
So what does the hybrid procedure involve?
You do a limited open surgery in the groin to physically clean out that old clot and scar tissue from the common femoral vein and endophlebectomy. Then, often in the same operation, usually in a specialized hybrid OR, you use guide wires and catheters to place stents in the iliac or iliofemoral vein from above. You might close the opening made in the femoral vein with a patch, maybe from saphenous vein or bovine pericardium.
Best of both worlds, potentially. What are the results like?
Early data suggested better outcomes when the stent extended down into that patched area of the femoral vein. More recent, larger studies on these hybrid procedures for severe iliofemoral blockage involving the common femoral vein have shown really promising results. Yeah, good one-year patency rates, significant improvements in symptoms, and quality of life scores. It seems that refining the technique over time, better pre-op imaging, maybe using access from a vein lower in the leg, always patching the femoral vein, routinely using an AV fistula and IVUS, intravascular ultrasound, plus aggressive long-term anticoagulation, like warfarin aiming for a higher INR, has really helped cut down complications and boost success. There are also reports of just doing the femoral endophlebectomy combined with iliac stenting for these chronic blockages.
Okay, let's switch to iliac vein decompression. This relates specifically to that May-Thurner compression. Yes.
Exactly, May-Thurner syndrome, that compression of the left iliac vein by the right iliac artery. We mentioned those internal vein spurs seen in early studies. Sometimes the term iliac vein compression syndrome is used for people with blockage symptoms without a definite history of a clot. It's more common in women, often 20s to 40s.
Symptoms.
Left leg swelling, venous claudication, pain, skin changes, rarely ulcers. And acutely, it can present as an iliofemoral DVT.
So when do you treat it surgically?
Well, while some might fix any compression found, the general recommendation now is to reconstruct only if the patient is symptomatic and has had a prior iliofemoral DVT related to it. And even then, endovascular stenting is usually the first choice. Open surgery is really for failed or inappropriate stenting cases.
And what does that open surgery involve?
Often, it's the Palma procedure again, bypassing the compressed area. But for shorter narrowings, sometimes direct exploration is done. You'd mobilize the vein, cut any compressing bands, maybe remove those internal webs, and potentially patch the vein open with vein or EPTFE. Some have even tried moving the compressing artery, but older techniques like using a silicone bridge aren't really recommended now.
What are the results of decompression surgery?
Studies reviewing reported cases suggest a high rate of significant symptom improvement, maybe around 80% or so.
Okay, one last surgical area. Suprarenal IVC reconstruction sounds very specific. When is that needed?
Yeah, it's less common for non-cancer reasons. The main indication is usually that membranous obstruction of the IVC, often linked with Budd-Chiari syndrome, where the liver outflow veins are blocked, causing liver problems.
Does that IVC blockage cause leg symptoms?
Sometimes, yes. It can cause leg swelling and claudication, though not always. If less invasive things like ballooning or stenting the blockage don't work, and the patient doesn't need a separate liver shunt surgery, then a bypass from the vena cava below the blockage up to the heart of vena cava tumoral bypass can be effective. An externally supported EPTFE graft is usually the best choice here.
That sounds like a massive operation. How's it done?
It is major surgery. Typically involves an incision through the right chest, across the lower ribs and diaphragm into the abdomen. You have to move the liver carefully to expose the IVC above the kidneys and the right atrium of the heart. Clamp the IVC, sew one end of a large EPTFE graft, 16-18 millimeter to it, then run the graft up alongside the blocked IVC to the right atrium, or the bit of IVC just below the heart, and sew the other end on there, usually using a special clamp that allows some blood flow while you sew. You have to be super careful getting all the air out. There's also an alternative approach from the front.
What are the results like for this complex bypass?
For Budd-Chiari patients, studies have shown good clinical improvement and graft patency in a decent number of cases. For other non-malignant blockages in that area, the experience is more limited, but long-term success has been reported.
Okay, so summing up this whole section on surgical treatment for iliocaval obstruction, what are the big takeaways for our listeners?
I'd say the main points are: 1, endovascular is often first line now, but open surgery remains crucial for specific complex cases. 2, success really depends on picking the right patient, meticulous surgical technique, the right graft choice, aggressive clot prevention, and close follow-up. 3. The Palma procedure works well for suitable unilateral blockages. 4. EPTFE grafts are valuable for selected advanced cases. And 5. Hybrid procedures might offer improved outcomes in the future for certain challenging situations.
Great summary. Now, let's pivot to pelvic congestion syndrome, PCS. This sounds quite different, more focused just on the pelvis.
It is, yes. PCS involves faulty valves or blockages in the pelvic veins, especially the ovarian veins in women. This leads to blood pooling and symptoms that can be really disabling, particularly for women of childbearing age.
And it's been overlooked.
Historically, yes. It was described way back, but only more recently recognized as a frequent cause of chronic pelvic pain. The official definition involves pelvic pain, perineal heaviness, urinary urgency, pain after intercourse, all due to reflux or obstruction in ovarian or other pelvic veins. It can also be linked to varicose veins in the vulva, perineum, or legs.
How common is it? This sounds like something many women might have without knowing the cause.
Well, pelvic vein issues like leaky valves and varicosities are actually found in maybe 10% of women. And pelvic pain is common, affecting perhaps 15% of women aged 1850. Some studies suggest PCS could account for pain in up to 30% of women with chronic pelvic pain.
Wow.
And another study found ovarian vein incompetence in about 10% of the general female population, with over half of those having PCS symptoms. But, and this is critical, you absolutely have to rule out other common causes of pelvic pain first, like endometriosis, fibroids, cancer. A thorough GYN exam is mandatory.
Good point.
And PCS can also be behind atypical leg varicose veins like on the buttocks or back of the thigh, or why varicose veins come back after treatment.
Let's touch on the anatomy quickly. What's the venous drainage like down there?
Blood drains from the pelvic organs mainly via the internal iliac veins, sometimes called hypogastric, and the genital veins, which are primarily the ovarian veins in women. The internal iliacs have lots of branches. Interestingly, sometimes they drain via two separate trunks. Valves aren't very common in the internal iliacs themselves.
And the ovarian veins?
They form a network near the ovary, connect with uterine veins, and then usually drain into the IVC on the right side at a sharp angle, and the left renal vein on the left side at a right angle. Variations are common. Normal diameter is usually under 5 millimeters on ultrasound. They do have valves, mostly lower down, but some women lack them. And they connect with lots of other pelvic veins, uterine, rectal, vaginal, bladder veins. It's a complex network.
So in PCS, what actually goes wrong in that network? What causes it?
We generally think about three main types or causes. Type 1 is the most frequent. It's reflux, blood flowing backwards, because the valves in the pelvic veins, especially the ovarian veins, aren't working right.
Why do the valves fail?
The exact reason isn't always clear, but hormones likely play a big role. Estrogen can relax blood vessels, and pregnancy causes uterine enlargement and vein dilation. Some medications that constrict veins have been shown to help symptoms. There's also an association with ovarian cysts.
Okay, that's type 1. What about the others?
Type 2 PCS is secondary to outflow obstruction. Something is blocking blood from getting out of the pelvis properly. This could be May-Thurner, Nutcracker syndrome, where the left renal vein is squeezed, renal vein thrombosis, post-thrombotic damage in the iliac's IVC, or even Budd-Chiari.
Right, so a blockage higher up.
Exactly.
Okay.
And type 3 is secondary to local compression within the pelvis, things like endometriosis, tumors, trauma sequelae, or scarring from infection pressing on the veins.
What are the classic symptoms women with PCS experience?
It often affects younger women, maybe late 20s, early 30s, frequently women who've had multiple pregnancies. Symptoms often improve after menopause. It's rare in men, apart from varicocele, which is sort of analogous.
And the pain?
The main thing is chronic pelvic pain, lasting 6 months or more. Often described as a dull ache or heaviness, worse with standing or sitting for long periods, worse at the end of the day, and often relieved by lying down. Pain during or after intercourse, dyspareunia is common, as is dysmenorrhea, painful periods.
Any other symptoms?
Yes, urinary issues like frequency or urgency, sometimes bowel issues like constipation. The pain is often one-sided but can be bilateral. Hemorrhoids are common too. On exam, there might be tenderness on moving the cervix or pressing around the uterus and ovaries. Tenderness specifically over the ovarian point plus pain after sex is apparently quite sensitive and specific for PCS. And you might see visible varicose veins in the perineum or vulva. Important to ask about those, especially during past pregnancies. Leg findings can include superficial vein issues or those atypical varices we mentioned on the buttocks or thighs, or recurrence after vein procedures.
So how do you pin down the diagnosis? What tests are used?
It's usually a mix of non-invasive tests first, maybe followed by more invasive ones. Duplex ultrasound is key, using both probes placed on the abdomen and transvaginally.
What are you looking for?
Dilated veins, blood flowing backwards, reflux, especially when the patient bears down, Valsalva maneuver. Pelvic varices are seen as multiple dilated, twisty vessels around the uterus ovary, usually bigger than 5 millimeters. An ovarian vein over 6 millimeters is pretty suggestive. We also check other pelvic veins and look for those collateral escape routes. And importantly, check the bigger veins like iliacs, IVC, renal veins for any obstruction. Leg ultrasound can also be done.
What about CT or MRI?
CT venography, say TV, or MR venography, MRV, can confirm the pelvic varices. They show up as dilated, tortuous, contrast-filled tubes. MRI is also good for spotting other potential pain causes like endometriosis. The limitation is these are usually done lying flat, which might underestimate the vein dilation compared to when standing.
And the gold standard test.
That's generally considered contrast phlebography. It's invasive, done via catheter from the groin or arm under local anesthetic. You inject dye to directly visualize the internal iliac and congenital veins, plus the bigger outflow veins, looking for reflux and blockages, often testing with Valsalva too. If Nutcracker is suspected, you can measure the pressure gradient across the renal vein.
Can you treat at the same time?
Yes, that's a major advantage. During the phlebography, if PCS is confirmed, you can often proceed directly to treatment, usually embolization. Doctors use specific criteria based on the venogram findings: vein diameter, how long contrast stays, congestion, filling of other veins, sometimes using a scoring system to confirm PCS.
And again, ruling out other causes is vital.
Absolutely critical. Before diagnosing PCS, you need to exclude those non-vascular causes like endometriosis, fibroids, cancer, even nerve compression, using symptom analysis and imaging like ultrasound, CT, MRI. Sometimes laparoscopy keyhole surgery is used, especially with the patient tilted feet down to make varices more obvious, and it can definitively rule out other pathologies.
Okay, so let's talk treatment for PCS. What are the options?
They range from medical therapy to conventional surgery to, most commonly now, endovascular treatment.
Medical options.
Medications like medroxyprogesterone showed some temporary relief in trials, but it often didn't last. Another hormone therapy, goserelin, seemed better long-term than medroxyprogesterone in one study. And a flavonoid medication showed some statistical improvement while patients were taking it. But none seemed to offer a permanent fix after stopping.
What about traditional surgery?
Various procedures have been tried, tying off ovarian or internal iliac veins, sometimes arteries too, removing ovaries, oophorectomy, or even hysterectomy with removal of tubes and ovaries, BSO. Some can be done laparoscopically, but they're still invasive. Hysterectomy BSO can be effective if medical therapy fails, but it causes surgical menopause and isn't an option for women desiring future pregnancy.
Which brings us to endovascular treatment. Embolization.
Exactly. Embolization has really become the first-line treatment in most places now. It's often done right after the diagnostic venogram.
How does it work?
Using catheters guided under X-ray, you selectively place tiny metal coils, or sometimes vascular plugs for larger veins, into the incompetent veins, typically the ovarian veins, and sometimes branches of the internal iliac veins to block off the backward blood flow.
Are there specific rules or techniques?
Yes, important not to block the entire internal iliac vein trunk. And when embolizing congenital veins, you need to block them proximal to any major connecting collateral veins to prevent recurrence through those pathways. Sometimes adding foam sclerotherapy, injecting a foamy drug like STS or politocanol, along with the coils, can improve results or reduce the number of coils needed. You can inject it before coiling or use a sandwich technique with coils on either side of the foam. Other blocking agents are sometimes used too.
Sounds effective.
Studies generally show it's very effective, often more so than hysterectomy for PCS symptoms. The best results seem to come from embolizing all the identified incompetent veins. Complications are rare, but can include bruising, contrast reaction, coil migration, very rare, DVTPE, or transient heart rhythm changes. And remember, if there's an underlying outflow obstruction like May-Thurner, that needs addressing too, usually with stenting. Current guidelines strongly support embolization for PCS caused by pelvic vein incompetence.
So endovascular embolization really seems to be the standard of care now for most women with PCS.
It certainly has become that, yes. And the reported success rates in terms of symptom relief are generally very high across numerous studies.
Well, this has been a fascinating deep dive into some really complex vein issues and how they're treated. To wrap up, what are the absolute key takeaways you want listeners to remember?
I think the main things are both iliocaval obstruction and PCS are real, significant conditions causing troublesome symptoms. While minimally invasive endovascular treatments are often the first step now, surgery still plays a critical role in select complex cases. Accurate diagnosis is paramount, figuring out the cause, extent, and impact on flow. And treatment success hinges on careful patient selection, precise technique, whether endo or open, managing clot risk, and diligent follow-up. Importantly, we've made huge strides in treating these conditions, offering real quality of life improvements for many people.
Considering this incredibly intricate network of veins down there and how seemingly small things like compression or leaky valves can cause such major problems, it really makes you wonder, doesn't it? What other hidden vascular conditions might be out there, more common than we even realize?
That's a really great question to end on. It highlights how much we're still learning about the venous system. And as these endovascular techniques keep getting better and better, it'll be fascinating to see how the role of traditional open surgery continues to evolve for these complex venous problems in the years ahead.